Shirley Fenton from the University of Waterloo. I'd like to welcome you to the next in our series of seminars on smarter health. This is a seminar project or seminar series presented by the Internet Project, which I manage, as well as the Education Program for Health Informatics. This seminar series was actually a follow-on from our investigation of using information technology in the community, for the community, we've spent the last several months looking how this information technology can be used in the health sector. In doing the seminar series, we've been sort of moseying along through our way of looking at the health system as a patient and looking at it in terms of the information technology as it's used and how it will be used. Just one logistic that I want to mention to you, our next seminar date is March 20th. It's again a Wednesday. Will be held here again at 4:30 in this room. 4 o'clock, thank you, till 5:30. And we'll be looking at how well are we doing, I guess, trying to measure how well we have come in terms of using information technology in health. So, why don't we get started? I'd like to introduce to you Amit Chakma. He's our Vice President and Provost, and he'll just give us a few words.
Thank you very much, Shirley. I'll be very brief because you're here not to listen to what I have to say, but to listen to what Bob has to say. But let me say that it is our great pleasure on behalf of the University of Waterloo to welcome you, Bob. We have great dreams at this university to play a significant role in health informatics, both in terms of education as well as research. We recognize that we have a long way to go, but thanks to the pioneers of our university, some are present in this room, we have taken a number of initiatives that will position, hopefully, this institution to move to the next level. And certainly the programs run by this group is just this starting point. As you know, we have strong expertise in IT area. At the same time, we also have a faculty of applied health studies. So it seems to us that by putting those two together and bringing in the expertise from our other disciplines that we can get from biology and other areas of our faculty of science, we really have the core elements that we need to launch a major health informatics initiative. And I hope that this seminar series will form core activity of that initiative, and we certainly look forward to your talk. And those of you who are here, I thank you for your participation. It is extremely important that we do this with participation and support from the community that we serve. And one of those history, of course, is that strong linkage with community. And certainly the topic of interest to us is community-based. We are interested in all of these things because we want to solve a major problem that our health system is facing. And certainly health informatics at least will be part of that future solution as we try to find a way out of the current challenge that we find ourselves relative to our healthcare system. Thank you very much.
Thank you, Aaron. Actually, that's a very good summary of why we're here, what we're trying to do, and I'm so glad we recorded that. May I ask Dominic Covey, the Director of the Education Program for Health Informatics Professionals, to introduce our speaker.
Well, it's a great pleasure that I have the opportunity to introduce Bob Bernstein. I met Bob about 12 years ago when we were, I was called in as part of a consulting company to assist in a major project that the family practice units in the academic medical centers in Ontario had taken on. They decided that there needed to be some kind of a consistent record across different family practice units, and got the Ministry of Health, fooled the Ministry of Health, I guess, into funding the project. And we got to work together with a group of order of about 12 people over a period of about 2 years. I can tell you both of our memories are very strong at that time, where we had probably among the most interesting meetings we've ever had in our academic careers. A group of very intelligent people, very driven people, and very interested people who got together and hammered out the nature of the family practice record. But before we did that, we had to understand what family practice was. It's a very interesting experience going through that, because I thought I knew what family practice was, and I discovered I didn't. Bob was a very important part of that, and as we went through the meetings, I began recognizing the kind of person he was. He actually comes to us for the PhD in genetics. And why family practice? He'll tell you that. He's interested. But you can kind of recognize the sort of academic approach he takes. At the same time, you can also recognize his nature as a physician. And in the meetings, it was very interesting because it was the deep academic content and also the human content was brought to it. And that was actually quite true of many of the people involved in that. Two of them wanted to help informatics from that group of people. Another one was from Toronto went into it. Since then, we've been part of something called the Institute for Primary Care Informatics. We meet frequently in international meetings. Bob's area of interest is controlled vocabularies, particularly in family practice. He's on the Classification Advisory Committee of the Canadian Institute for Health Informatics. He's a Canadian representative of the World Organization of Family Doctors in the International Classification Committee. He's very involved in the issues of vocabulary, particularly in family practice. In addition to those, he right now is an associate professor in family medicine at the University of Ottawa. He's the head of the Medical Informatics Research Group and the medical director of the Family Medicine Center at Elizabeth Bruyere. I call it the Cheese Pavilion. The Elizabeth Bruyere Pavilion of the Sisters of Charity of Ottawa Health Service. So I welcome you. I'm glad to have you here, Bob, and hope you. I know from your presentation you're going to give us a lot of interesting information.
Thank you, Dominic. Thank you, Alex. Welcome. I'm a pretty informal kind of speaker, but and so feel free to ask questions and participate. I find that when I'm a passenger in a car, I don't learn where I'm going. When I'm driving the car a little bit, I tend to learn a little bit. At McMaster University, these things are called large group discussions. We don't call them lectures anymore. My partners in crime, who I will acknowledge here, are Gary Hollingworth and Gary Finer. Any of the work that we've done together in the Medical Informatics Research Group has been very much a collaborative effort. And what I'm presenting you today is a synthesis of many things that we've all worked on together. You ever feel you're on the verge of an incredible breakthrough?
I got a card like that in Winnipeg.
So who am I? Why am I interested in electronic information systems? Well, I'm a university teacher of family medicine. You've already found that out. I'm a GP. I no longer call myself a family practitioner. For one thing, I can't define family any longer. For another thing, I think the French term is far more romantic. I'm an omnipraticien. I would call myself a generalist physician, I guess. I take care of people from cradle to grave. I take care of anything from upper respiratory tract infections to schizophrenia, well babies to heart attacks. I see as many as 30 patients in a day, and I'm not a GST collector. That has some significance in many ways, but
I'm not designed
as a person to collect data for somebody else. I have my own job to do, and I need the data for that. These are the questions that Dominic posed. I'll go through them one by one, but I'm not going to go through them in any detail right now. If we make an adequate investment in the technologies and human resources to deploy them, what shall we reap? If we keep on the way we have been, on the other hand, what will we lose? What can the system be tomorrow that it cannot be today? And examples of new capabilities and deliverables in the health system would be nice to see. What would the beneficial impacts be on the cost of healthcare, access to the system, the quality of care provided, etc.? How would the lot of the health planners, the provincial ministries, the regional health organizations, the administrators, providers, and the patients improve? And how will we know we've succeeded is actually the topic of the next seminar in March. So I'm not going to get into that. The next is an ordinary Joe away from home. What I'm going to talk to you about today really is going to answer Dom's questions indirectly. In reality, what I'm going to talk to you about passes James Watson's gossip test. You know who James Watson was, one of the co-discoverers of the structure of DNA. So this comes from my book. Watson said that good science is done about issues that you talk about over lunch. It's the stuff that drives you, interests you, keeps you going, that the arguments keep going about. And so what you're going to hear me talk about is the stuff that's turned our little group on and got us interested in what we're doing. I'm going to answer some of Dom's questions. I'm going to do them indirectly. I'm going to do them with a very much a clinical sort of focus because I do come in from a clinical background. And I will state at the outset that the technology is there to serve the patient. It is not about management. It is about quality. The computer is demanding a complete service overhaul every 6 months and 2 weeks off in August. Wouldn't mind that myself. By the end of the session, here's some objectives. You will understand how the science of primary care is different from specialty and institutional care. You'll be able to define clinical decision support systems and know the evidence for their use and some of the limitations. You'll understand potential benefits of electronic information systems and their limitations in primary care. You'll understand the concept of episode of care as a relevant data model for collection of standardized data and understand the power and promise of that kind of a model. And so let's get right into the science of primary care, the water we swim in. This is a question I ask my students. They come into family practice. They've been through medical school where they've basically been through every rotation from surgery to pediatric urology. And I ask them this question. In one word, what distinguishes general practice from specialty medicine? And anybody want to ask your guess? What do you think? You've all been to a family doctor. Some of you may have been to a specialist. But what do you think? Unpredictable. Sorry? Whole. Okay. Any other ideas?
I guess the cost.
Yeah, boy, exactly. But actually, from a scientific point of view, the word is prevalence. And what I mean is, I'll show you. What do you think the most common reason for taking up a family doctor's time in an office is? So that is to say, what reason do patients visit the doctor most often for? Take a guess. No, the colds are up there, but actually the correct answer is hypertension. There are more visits for hypertension. These are worldwide statistics. I'm going to show you some statistics in a moment, but this occurs worldwide. There are more visits for hypertension than for any other single clinical entity in family practice. What proportion of encounters do you think are hypertension? If that's my most prevalent thing, what proportion of encounters do you think are prevalent? 7%. There's the list of the top, the ones that make it over 1%. I'm going to tell you a story. Many moons ago, back in 1982, we had a wonderful computer system hooked up with 3 IBM PCs with 64K of memory. We finally upgraded it to 640K. We ran a QNX operating system. We ran 25 dumb terminals that we could do statistics. And I'll tell you, what we have now is much better. One of the statistics we did was the frequency distribution of diagnoses. So when people would come to see us, we would write down on an encounter form the reason why they came to see the doctor. And I asked the programmer, actually wrote a program to do the queries of the database, give me a frequency distribution. I got back 10 things. And I said, look, I know personally I've entered more than 10 different things. How come I only see 10? He said, well, I cut it off at 1%. I didn't think you'd be interested in anything at less than 1%. I didn't. Geez, Gordon, everything is less than 1% in family practice. Here's what you get that's over 1.5%. Hypertension, anxiety, upper respiratory tract infection, bronchitis, prenatal visits, congestive heart failure, ischemic heart disease, chronic obstructive pulmonary disease, annual physicals, osteoarthritis, and acute otitis media. Those are the things that make it into the top 1.5%. And the rest of medicine is everything else. So we swim in waters of low prevalence, and that makes us very different from specialty medicine, and it makes the kind of data we collect, and it makes the paradigm of diagnostic thinking different. And we'll get into some of that in a moment. So if we're going to do decent informatics in the healthcare system in the future, we need to account for a number of things. One is the complexity of everything. In spite of what your doctor puts down on your OHIP card when you see him or her, which is a single billing diagnosis, on average worldwide we see 3 to 6 health problems per encounter. We see people early in the course of disease at a time when their symptoms are undifferentiated. We have to deal with the longitudinal person-oriented information and the evolution of health problems over time. That is to say, I see patients literally, I've seen some in my practice since I was a resident in family medicine. I've followed them for half a lifetime. And it's the same record. And we have to deal with the usual problems of information overload that everybody has to deal with. But what's really different is we don't have a hospital informatics department or medical records coders or any other kind of institution that supports primary Let's look at clinical decision support. In the beginning, 3.5 inches. This was the record many years ago. I apologize for the graphics. I just have fun. Then it came Clem MacDonald. There's one more graphic. Clem MacDonald. So you remind me a little bit of Dominic Covey. I'm a Clem MacDonald junkie. When I go to conferences, I will follow this guy around and listen to his panels. Clem was the first guy to do any real research on clinical decision support systems in medicine. And what he did was very simple. He first of all thought out of the box. He said, I want to find another profession that is information overloaded as much as medicine is. And his hypothesis was that we make medical errors not because we don't know what we're doing, but because we have so much information coming at us at one time, we can't make the decision. So guess what profession he chose to examine? Air traffic controllers. And he went to the air traffic control literature and found out that's exactly what happens. So what he did was he had his programmers in Indiana write a medical clinical decision support program. And it was a series of hard-coded rules based in code. You couldn't modify it. But it had simple stuff. And for those of you who are not clinicians, it probably won't matter that I say this. But things like if you're on a certain medication, check a certain blood parameter. If you're on digitalis, check the test. Real simple. He had 137 rules. He turned them on, and people followed the rules. Okay? That wasn't enough. He turned them off. What do you think happened? They stopped following the rules. It had nothing to do with knowledge. It had everything to do with information overload, not being prompted with the right information in the right place at the right time. So that was his paper called Protocol-Based Computer Reminders, the Quality of Care and the Non-Perfectibility of Man. New England Journal, 1976. That was the beginning. That was like the discovery of 23 peer students. The computer is a powerful ally in managing vast amounts of health information. This is mother of stuff, but I'll say it anyway. The computer can organize, process knowledge, information you would otherwise forget, overlook, or never have access to. Clinical decision support systems are needed to allow a physician to actually make use of an electronic medical record. And what is a CDS? Well, it may or may not be used at the point of service. It can take many forms, such as warning of potential drug interactions, or providing information about costs of diagnostic procedures, or clinical practice guidelines, or reminders to follow up on routine things, or suggesting an entire care plan if you wanted to do that. A fully integrated clinical decision support system in an electronic medical record analyzes the incoming stream of clinical data, searches for unusual patterns, potential adverse events, makes recommendations about possible actions to remedy the situation, and it takes the computer from simply being a passive observer or reporter of facts to being an active participant in the physician practice. It provides the professional with the important information, and here's key, at the right time so that he or she can make the right decision about patient. And as we go along with an ever-burgeoning amount of medical knowledge and medical practice, it makes it impractical to use our memories to do this all the time. And by not doing clinical decision support, we're probably, and I can probably demonstrate this to you with other studies, we are increasing the cost of care by not using these things. I'm not going to get into this too much. Just some examples of what CDSs can do. They can do feedback, they can do data organization, they can actually do some intelligent action, they can do communication functions, they can do substitute therapy alerts. There's a cheaper drug for this than what you're thinking of prescribing. They can do allergy checks, drug interactions, and things like that. They can do parameter checks for overdosing, underdosing, abnormal lab results. They can do redundant utilization checks. Here's an interesting one. 65% of such alerts result in the clinician retracting the order for something that they found to be redundant. On the other hand, 35% of these alerts are ignored. Now, that doesn't mean the alert was wrong. It means that the computer doesn't have clinical judgment, and you have to be able to override it. So there's still a place for clinical judgment. You can process relevant information at the point of care, things, time-based checks, templates, and so on. You have profile displays, and so on. That's an example of clinical decision support. Excuse me, the machine is making a funny noise and the little light is moving in a straight line. Yep. This is an example of clinical decision support. This is a program that my colleagues and I wrote. It's called Promptor. It stands for, sorry about the acronym abuse, probabilistic method of prompting test order in family medicine. It's a very simple way of saying if you have a certain probability of disease and you apply a test to it, how likely is the test to be correct? And I won't get into the mathematics of this. Is actually fairly simple stuff. We did a randomized control trial. Basically what it says, if you're going to order the test, before you order it, we can give you some estimate of the likelihood this test is going to give you new information. And And so we did a randomized control trial, divided our residents up, and our staff physicians up into two groups, gave them some standardized clinical scenarios, and asked about test ordering. In one group, we gave them prompt, the other group we didn't. Not a complicated design. There was a 38% reduction in the numbers of tests that these physicians would have ordered, and a 12% reduction in costs. And the really interesting thing, which is not on the slide, is some tests were ordered more frequently when you had good information about them, and most were ordered less frequently. So the assumption here is that people are doing the right thing, not just cutting costs. They give them the information, they do the appropriate stuff. There is evidence to show that when physicians perceive that a clinical decision support system facilitates their practice, they will learn to use it even if it requires changes in how they practice. That has implications for change management and integration of electronic systems in doctors' offices. In order to ensure acceptance, they must do the following. And this was our mantra for a long time, and I'm proud to say that the last bullet is now something that has been accomplished at our Family Medicine Center. They must provide immediate benefit to the physician and patient. They must be flexible enough to fit into normal physician workflow. And they must, above all, be available at the point of care, i.e. a computer in every examining room. That was our mantra. We finally did it. We've been running a fully integrated electronic health record system in our Family Medicine Center for about 8 months now. Benefits and risks. You like that one? A little background. 1985, there was a survey done. About 5% of physicians were using the computer for anything other than office management stuff, billing and accounting and usual stuff. 1995 was part of a seminar a symposium we did at the American Medical Informatics Association. 5%. Geez, it's the same 5 guys, by the way. Nobody's changed. And in the year 2000, I said, we're going to do this. We're going to have a shareable health record and everybody's going to use it. And they actually started to promulgate new standards and new initiatives to try and get that to happen. Another example of clinical decision support. So, in typical academic fashion, you did literature, you can able to find out what's going on by actually asking questions to the literature. We actually did this in a relatively systematic way and asked the College of Family Physicians of Canada Library to do a literature search for us, so they were able to look for stuff that's not in the usual literature. We found 38 relevant articles. The use of electronic medical records in primary care. 20 were some form of experimental study, and they looked at 4 areas: clinical decision support, guidelines, patient issues, and full electronic medical records. And I'm going to go through some evidence. There is some evidence to show that physician and patient reminders, treatment planners, and patient education are effective. There is evidence to show there is improved preventive care and improved drug levels. There is evidence to show that when you provide decision support, costs of some drugs go up and some go down. That looks remarkably like the study we did on lab testing. People do appropriate things. What about guidelines? Compliance with guidelines increases. This is 2 different studies, 3 different studies, from 6 to 15.5%, 6 to 35% in one study, 15.6% to 32% depending on the study. So people follow guidelines a little bit better. I'm going to tell you an interesting story though. Bob Elson is a guy just like me in, I believe he's in Seattle, west somewhere in the States. And he was interested in the guidelines for how you manage cholesterol. It's a relatively common problem in family practice. And what he did was, he didn't have a computer record. So he took all the information about cholesterol about his practice and he put it onto a spreadsheet format. And so he would have the cholesterol levels and the breakouts of the good and bad cholesterol and the drug information and all that kind of stuff. And he put it out as sort of a time-based flow sheet. Gave some doctors the flow sheet, others not. He did not tell anyone what the cholesterol management guidelines were. He then looked to see how well the different doctors followed the guidelines. Guess what? Given the correct information presented in the correct way, people follow the guidelines even though they don't know the guidelines the next generation. Give people information in the right place in the right time and they do the right thing. They're professionals. Patient issues. None. Patients are either more or less satisfied. There seems to be no depersonalization. The general comment that patients make is, my God, I can't believe you haven't been doing this all these years. Even my car garage has a computer system that tracks things better than you have. There is some evidence to show that the nature of the encounter changes. When you prompt for preventive care, more time is spent doing preventive care. Sort of goes without saying, but you have to say it. But there is less patient-initiated social talk and more doctor-initiated talk. Unclear what that will mean in practical terms, but it's true. Electronic medical records will increase preventive tasks. Better blood pressure control. Dominic, you probably don't remember. That was a study we did at University of Toronto. There you go. More complete problem lists and medication lists. The chart information and the computer information is not always the same. That's interesting. Not clear why that happens. There's more complete documentation for decision making, so these things protect you a little bit from some medical legal risks. Better communication with consultants. And here's an interesting attribute of information system. When I give you a drug to cure ulcer, there's a really simple outcome. I can look to see whether the ulcer's gone, whether your pain is getting better. If I give you an information system that prompts me to do certain preventive tasks, that's a bit remote from what actually happens to you as a patient. And so if you ask the question, what outcomes could I measure in information systems so that I would know that things were getting better? One of the attributes of good information is to make better predictions. And actually, one very clever study showed that you're better able to predict heart disease from patient information when you have an electronic medical record. It was a really neat way of getting around the idea that the computer doesn't actually influence care directly. The computer handles all our applications. Okay, here's the dark side. The data entry problem. It takes between 50 to 90 seconds longer to enter your chart notes when you use a computer than when you don't. The average family doctor sees 30 to 40 patients a day. Do the math. Patient volume stays the same. You don't free up any time. You don't get more patients. Costs in one academic system that was published and widely, the information about it was widely spread. Costs killed it. Estimated costs in one economic analysis are that electronic medical records will cost between 7.5% to 13.5% of the enterprise budget, and that is an astronomical amount of money when you consider how much money you spend in healthcare. And one economic analysis suggested that the societal benefits may not be worth it. The costs exceed the benefits. There's not a lot of evidence we should be going here yet. Our lament, this is now getting more personal and back to family practice. Electronic medical records in primary care have so far failed. And there are a number of reasons why they fail, and for the computer science people, this is where we've got to solve the problem. One problem is data input. We have not solved the ability to get information into the system in a way that is effective and organized and quick. I type 8 mistakes a minute, as I've done many times. Part of the problem is that users have not been involved in the design very much, so that the interfaces have not been very practical and haven't been set up for me to use in the normal process of the way I take care of patients. But part of it is that there are problems with data entry that everybody has, and I don't know how to solve it. Standards. The most important issue here, actually, is conflicting uses of the data. If I put data into my electronic medical record for clinical care, and the Ontario Ministry of Health and Long-Term Care is going to monitor my actions as a physician and do punitive action on me if they don't like what they see, I'm going to enter a different subset of data. I might just enter the stuff that makes me look a little bit better. So there's a bias immediately. You can't serve two purposes with the same set of data. If the government needs to monitor me, there are other ways of doing that. But if I want to have real clinical data, I've got to be able to do that unfettered. There are other issues about standards. I'm not going to get into it. Standards are a huge problem in why electronic medical records are so far failed. One of the things to come to, of course, is that when there are no standards and you choose a system vendor, and that vendor goes belly up, and we've gone through 4 accounts in our family medicine center in the last 10 years, you can't get the data out unless you're real clever. I figured I'd do it not because I'm clever, but because I wouldn't have the whip taken to get data out. But most doctors will not have the time, not in an academic setting, they will not be able to get data out. And when their system goes belly up, their data is gone. Error. We did a little study with medical students. This was an interesting one. We asked them, what do you think are the biggest barriers to using electronic systems? And actually, the biggest barrier for them was fear of error. System crashes and that kind of stuff. Then you need to have redundancy. You have problems with stability versus the amount of functionality you have. There are problems with using it for everything or using it for nothing and not being sure that the whole thing has all the information in it. There are problems in maintaining networks. Boy, tell me about that one. And then you're penalized for being smarter. if you put all this stuff into your office, you have to pay for the hardware, the upgrades, making sure that it's accessible at every point of care. So you need multiple terminals or some fancy handheld device that costs a lot of money. You need to have redundancy and backup. You need to run a networking system. Meantime, you're losing 40 seconds per patient per visit, and nobody's paying you for any of this. And the next time Microsoft upgrades to Windows, what's it going to be after XP? ZP? Waterballoon? I don't know. The next time Microsoft upgrades, you've got to upgrade everything else that you're running. It's pretty much unsustainable, which is why that 5% level hasn't gone up very much. So what do we know? Parts of the electronic medical record improve care. The whole EMR is more costly. Opinions, if you read the literature, are uniformly positive. The evidence has been uniformly negative. It's very interesting. Let's talk about integration of healthcare, because one of the promises that you get out of using electronic systems is that you can start to integrate healthcare. You can get a better idea of what's going on in the province. One of my favorite examples is we don't know how many diabetics there are in Canada. You can't count them. I'll make it even more difficult. You can't even count the number of patients in Canada. We have no way of uniquely identifying people across provinces. I work in Ottawa. Literally, I could throw a stone across the Ottawa River and hit the Museum of Civilization in Hull, and my patients move from Quebec to Ontario, and they change health number. They have the same disease, they're the same patient. I have no unique identifier. Here's an example of what integration might help. Now, why on earth would you tell me you were allergic to penicillin? Wouldn't it be nice if I had that information, somehow automatically, that when somebody else realized there was an allergy to penicillin, that I got that information from my patient as well? It would be nice to do. So, some of this stuff comes out of some thinking I did when the Restructuring Commission came around and started, in my opinion, do some very silly analyses. But this is what the healthcare system looks like. There's primary care and tertiary care, respite care, laboratories, long-term care, all kinds of stuff. And the patient is seen at many disconnected points and times in the healthcare system. And it doesn't go that way in some kind of orderly fashion up and down like a ladder, but the Restructuring Commission actually thought it did. Actually, this was the diagram they published about healthcare. They thought it goes from some rostered population to community care, to primary care, ambulatory specialist. And it went, and they literally had those arrows back and forth like that, like somehow there's a linear fashion that people flow through the healthcare system. Then they published this diagram, which I thought was really organic. That's what runs everything. And so I started thinking about that. The patient is my specialty. One of my students said, I'm not a specialist in any particular disease. I'm a specialist in patients. I do primary care. I do secondary care. By the way, these names have real definitions in epidemiology. Primary care tends to mean I see the patient before they see somebody else. Secondary care means I'm doing referral care in some path. I'm not the first line of care. I do some tertiary care. I work in a hospital and I get referrals in care. I do community care. I do respite care. I do long-term care. I do my care in the office. And I do so all this stuff. This is the life of any office practice. And so what we really need is some sense of circular integration of the healthcare system, and you need that through continuity of care. And continuity of care occurs for two reasons. It occurs because you have a low-tech solution to continuity of care, the personal physician who knows you and knows your healthcare, and can evaluate all this information in the context of the real patient. And then you need some continuity of information, which is a high-tech level. But you can't have one without the other. You can't have integration just with the physician, and you can't have integration just with the high-tech integration. I think that's the case. The healthcare system of the future is going to have both of those things. You need to have data which is available, standardized, so we all know what we're talking about. Things are called the same thing. Valid, reliable, and here's the hooker, concise. Remember I talked about we are taking care of patients longitudinally for a lifetime. If they have 2 or 3 hospitalizations, and each of those hospitalizations lasts 10 days, and they get 3 blood tests a day, okay, and that blood test, and each of those blood tests has 17 different, I say 18, they say 18 different parameters. How much of that data is relevant 6 months after? Do you really want to know that stuff? Do I care any longer? So it has to be concise, and it has to be relevant data. We can't just simply accumulate all observations. That isn't going to work. When we do that, we'll have data for patient care, and we'll have data for analysis of health. So, circular integration of the healthcare system requires continuity of care through a personal physician and continuity of information through information technology. And we need both conceptual compatibility through standardized terminology so we all talk the same language. Oops, what did I do? No. There should be another part. We also need technical compatibility. We need to be able to read and write each other's stuff. I'm not going to get too much into terminologies. It's an arcane subject. And if you have questions, I'm going to ask afterwards. Let me come to the next bit, because this is the stuff that really is getting us turned on now. What's the concept of the episode of care? Well, if you were to measure primary care, if you were an epidemiologist and you wanted to measure what was going on in the community, what would be your unit of observation? Is it a patient? Doctor? Encounter? A diagnosis? An episode? And an episode, simply put, is the patient with the problem over time. It's a person-oriented approach. This concept comes from the World Organization of Family Doctors, abbreviated to WONCA, WONCA. Now, there's a story behind that. WONCA stands for something else. They changed the name, but everybody knew what WONCA, at least I think everybody knew what WONCA was. So it remained WONCA, even though we're now the World Organization of Family Doctors. The work that I've done with the International Classification Committee, this is a concept that came from two of the members of the Classification Committee, Hank Lamberts of the Netherlands and Morris Wood of Virginia in the States. Morris is now retired. Hank is still on the committee. And their thinking, this was really a breakthrough in how we can see how to collect data in the healthcare system. An episode of care, oh God, I'm going to kill me on the spelling errors. I'll be nice to. I'm missing the P in episode. Yeah, there we go, episode. Is distinct from an encounter or an episode of illness. An encounter is when you go see your doctor for something. That's an encounter, it's discrete, it's got a time, you're done, you're out, that's it. An episode of illness is, for instance, when you go to the hospital to have your gallbladder taken out, that's it, you're out. But an episode of care refers to all care provided for a discrete health problem or disease in a particular patient. It is a health problem or disease from its first presentation to a healthcare provider until the completion of the last encounter with that same health problem or disease. It's got some elements to it. So you're going to record information in a standardized way. Here's how we'll do it. We'll look at the reason for visit, reason for encounter, RFE. We may or may not look at clinical findings. We don't have good ways of doing that yet. We don't have good ways of recording it yet. We'll look at health problems and diagnoses, which are, in this part, it's called episodes.
You're being worked on for two different things. Is that two episodes of care? I mean, two.
Yes.
Okay.
Yeah, I'll come to that precisely. Yeah. We'll look at processes of care and interventions. And we'll look at outcomes, and there are some outcome measurements that apply to primary care. And we'll look at transitions, and the transitions are one or more encounters, including their changes over time. I'll come to this in some detail. Here's an example. First time you come to me, first time a patient comes to me, to make it personal, feeling tired. There's a fairly common complaint in medical practice. I do my physical examination, and the best I can come up with is the medical term fatigue. That's fancy. They're saying feeling tired, except now I agree with the patient. And so I do a couple interventions, and one of them happens to be a test of hemoglobin. The next visit, they come back, and the reason for encounter is to get their test results. They're now shown to be anemic. And I don't have any better diagnosis than that, but I have some suspicions as to where the problem might lie, and I send them for a barium enema or a colonoscopy or whatever is necessary to figure out where they're bleeding from. They come back the third visit for their test result. The test result shows they have cancer of the colon, and I refer them to a specialist for the appropriate therapies and operations. Meantime, the health problem has gone into transition. What was called fatigue on the first visit became anemia on the second and colon cancer on the third. No one records data yet. It goes in that direction. The reason for encounter is the agreed upon statement why the patient enters the healthcare system. It is the demand for care by the patient. It's a patient-oriented thing. It may be a symptom or complaint such as headache or fear of cancer, or a known disease such as follow my diabetes. It can be a request for preventive or diagnostic services. It can be to get a test result or administrative things. It is the patient statement clarified by the doctor. As I said, it's a way of doing person-oriented medicine. Listen to what patients say. And we try and record that in a standardized way, in a way that reflects their concerns. That's a true primary care concept. That's not what happens in specialty care. And I'll make the point that primary care is driven by reason for encounter. When you come to me with fatigue, how I manage the symptom of fatigue is quite different than if you present your workload stress as fatigue than if you're presenting your workload stress as I'm anxious. So you'll get a different cut at it from me because the reason for encounter determines a little bit of what my possible diagnosis. By the time you reach the Heart Institute and need a heart transplant, the reason for encounter is no longer all that relevant. I'm not going to go through this right now. We'll just go a little faster here. Transitions. An episode may occur over many encounters, such as diabetes is a lifelong episode. Every time you see me for diabetes, it's the same episode. Each encounter may have more than one episode assessed. We said at the beginning that the average encounter has between 3 and 6 health problems that are addressed, so there are 3 to 6 different episodes addressed in one health encounter. And there is therefore a many-to-many relationship between episodes and encounters. How do we represent the knowledge? Bleeding started in the rectal area and continued all the way to Los Angeles. That's pretext. She fainted and her eyes rolled around the room. That's more pretext. So I was listening to Dick Alvarez, who was the head of Chi-Hi, tell these stories in a way of saying pretext is terrible, don't we need coded data? At first I laughed, I thought, yeah, that's a pretty good idea. But then I thought, wait a minute. Bleeding started in the rectal area and continued all the way to Los Angeles. Even though it's a malapropism, doesn't it tell the story? You know what happened. It's wrong, but you sort of got it. The brain can integrate that stuff. If I were to code that in some manner, chances are you'd get it completely wrong. You wouldn't know what was going on. And if you had the computer parse it, it would be completely obvious. So there's value in pretext. There's another one. We hold that all men are created equal. I don't think we mean that any longer. The words we use are very important. So we have requirements to have good terminologies for reporting healthcare. They have to be rich in reasons for encounter and symptoms. The current terminologies out there are not. They have to use clinical language. They have to be in Canada bilingual. They have to have synonyms and pet terms. Who knows what seal finger is? Seal finger is a chlamydial infection of the fingernail found in people in Newfoundland and Labrador and in the Arctic when they get it from removing the skins from seals. So that's not used down in Toronto very much. But it has to be there for them because they record seal finger. It's common. You have to eliminate ragbags. Okay, where are ragbags? The International Classification of Diseases, the International Classification of Primary Care, all have terms that go other diseases of the respiratory system not elsewhere classified. And if I said to you, you have another disease of the orthopedic system not elsewhere classified, that doesn't help you all that much. Nor does it help me in managing clinical care, because I don't have a clue what you have to tell you that. It presumes a couple of things. One is that term has some meaning clinically. The other is that I have to know everything else that's in the classification or terminology to know what isn't included in that. So you've got to eliminate all those kinds of terms. You can't use them. You have to have things which have meaning and stand alone. And no classification system has that. So it has to be relevant to the discipline. I'm not interested in some of the arcane stuff that the neurologists do. I'm interested in some of the more broad brushstroke stuff that they do. And it has to map to some standards so we can look at statistics in healthcare based on some comparable realities. And so we actually wrote our own terminology to do this. It's called ENCODE. It stands for Electronic Nomenclature and Classification of Disorders and Encounters with Family Medicine. More accurate. Okay, so that's the direction we're going in to look at episodes. But here's what really happens when the doctor sees the patient. They're going laterally like that. Right? And so we have to record things this way. The reason for encounter, which may be a symptom or complaint or problem, or it may be a request for an intervention. And then we do an intermediate intervention, such as I examine the heart or the lungs or something like that. And then I have clinical findings for which there's no good terminology to collect right now. And a health problem, including how certain I am, and whether this is an ongoing problem or a finished problem. And subsequent interventions like referrals and tests. And if you can figure them out, outcomes from there. I'm not going to get into those. And these are repeated at each episode for that encounter. For every episode that I'm seeing that patient today, I will do this kind of data recording. It will be repeated at each encounter for that episode. So when they come back 6 months later to follow their diabetes, I'm going to do the same thing. Software maintains the link. And the problem in all of this is how much coded data, how much burden can you put on the doctor to do the coding? And so there's different levels of complexity you can use with this. There's a point to this in a moment, so you're going to get it in a second. You can record, currently the most complex data model I've seen records between 1 to 4 reasons for encounter, a couple of other elements of history, a couple of negations. So negation means the patient presents with constipation but does not have weight loss, and you record that. A couple of intermediate interventions, a couple of subsequent interventions, and so on. So the only way to do this is through electronic patient records. Terminology must be reason for encounter rich, and we're using ENCODE. You still have to solve the problem of complexity of data recording And we wrote a little program called PEPPER. Sorry, more acronyms. PEPPER stands for Portable Electronic Patient Profile and Episode Record. Guess what its companion program is called? SALTED, Statistical Analysis of Long-Term Episode Data. That's PEPPER. That's a very simple list manager. Actually, it's much more complicated underneath, but that's the opening screen. That's a profile of my patient. It's got chronic problems, past history, chronic medications, the visits, actually the chart notes are right over here, vital signs, reminders, allergies. If I hit this button, it actually prints on the screen and it prints the paper even more information than you see on the screen. Anytime I push a button to do something, it shows me the relevant information I need to do the task. So when I wish to re-prescribe a drug, it comes up with the drug list and the allergies and a one-click access to a drug interaction model. So it's process company. The pharmacists in town love it. Two pharmacies have phoned me up and saying, what a novel idea, prescriptions I can actually read. Let's look at what this gives us, the transition project. I've mentioned Hank Lambert's. His transition project, transition comes from the transition of the healthcare labels. He did this with 43 general practitioners and 24 practices over a year. There were 270-odd thousand encounters, 390-odd thousand reasons for visit, and about 235,000 episodes. This is a picture of Hank Lambert. Actually, it's a lie. I couldn't find a better picture. This is the kind of information you get. Now, he was recording one reason for encounter and one health problem label per encounter per episode. So it wasn't fancy, just one data element at a time. And so you're able to ask a question to the database. This is just one example, and I got the data set actually on this computer. We can play with it if you want. This was a question that I asked of Hank's database that said if I have men in the age group 65 to 74, you see that up over there, who present with a reason for encounter of D12, which is an ICPC term called constipation, what are the top 10 episode titles with this as the starting problem in order of probability? And lo and behold, that's what you get. 71.4% of 65-year-old men who present with constipation end up with a diagnosis of constipation. But hold on a minute. The textbooks, and particularly the educators in medicine, would have you believe that change in bowel habits is a dangerous sign in elderly men. And when you look to see how frequent cancer is, it's actually 1.8%. 65-year-old men. So what we start to get is a better cut, a more intelligent cut at the probability that symptoms mean disease. And when you start to combine that to say if I have more than one symptom, or if I have one symptom and one negative symptom, how much more power do I get? And you start to be able to refine clinical judgment on a population basis, start to understand the scientific basis, the epidemiology of general practice. And that's what the power is. So Sohal Goyal is my graduating resident, our chief resident. He came to me about 3 years ago to do an elective in family practice, and we were just about to do a presentation to the college, to the section of teachers at the College of Family Physicians in Canada, and we had him play with Hank Lambert's database, and that's what he said. This can change the way you practice medicine. So we went, just to tell you a complete story, we went to, we did this seminar with about 20 people in the room, many of whom were the heads of education departments in family practice. And then Sohal went to interview for his residency programs. We went to McGill, got an interview about one of the guys he'd given the seminar to, who looked at him and said, I thought you were a professor of family practice at the University of Ottawa. No, he was just a student at that time, but got grabbed by the power of this stuff and was able to present it very powerfully as well. So, to put this in scientific terms, we start to be able to get the sensitivity and specificity of common symptoms and symptom clusters. Sensitivity, anybody know what I'm talking about? Let me give you an example. A test is sensitive if it picks up people we know have disease. A test is specific if it only picks up people we know have disease. So an example of a sensitive test would be the test that we do for thyroid disease called the TSH. Very sensitive. It picks up 99% of people we know have thyroid disease. An example of a test with lousy specificity is the rheumatoid factor for rheumatoid arthritis. It only picks up about 20% of people who we know have rheumatoid arthritis. An example of a test that is not specific is the PSA, prostate-specific antigen. The guy sitting in the audience. That test can be elevated in a variety of conditions. It also is very sensitive to cancers, but it's elevated in so many other things you can't tell sometimes. So what we're able to do by collecting data in this way is to get a pretty accurate idea of the sensitivity and specificity of symptoms and symptom clusters to know which ones are really going to be predicted. Then you take that, add it to the prompting system that we built to guide laboratory testing, which is based on these probabilities, and you can start to get effective diagnostic testing, and as I said, 38% reduction in numbers of tests and 12% reduction in cost. And that's just one small clinical decision support system. So when we have data like this, we understand what we do and its value. The Ministry of Health will understand what we do and its value. We can do real-time clinical decision support. We can affect lab testing and procedures, outcome measurements, and ensure that we practice better medicine. This is a quote from the International Classification of Primary Care, Oxford University Press. That was one of the publications of the International Classification Committee. The large majority of personal healthcare needs, the comprehensiveness, the integration, accessibility, and accountability of the healthcare system can be assessed when episodes of care are classified with ICPC in a computer-based patient record. So, this was what we intended to accomplish. A little bit about the science of primary care being different from specialty institution care, a little bit about clinical decision support, some understanding of the benefits and risks and benefits and limitations of electronic systems in primary care, understanding the concept of episode of care and the promise of electronic information. So, I'm now going to get really opinionated. Because I really did think a little bit about Don's questions. I'm just going to throw this out for discussion. That's the dark side of the force. That's the light side of the force. Private sector, public sector. Bound up by rules of privacy and confidentiality, so you can screen from doing anything, or free by anonymity of information. We have a whole think tank on this. Proprietary systems versus shareable with standards. Bottom line based versus evidence based. Encounter epidemiology versus episode epidemiology. Supported by advertising and other marketing. Supported by cost savings business case. Management information because management want it. Clinical information which can be spun off for management. Institutional care to community care. Secondary data entry by people who aren't at the point of service. Primary data entry at the point of service. And there's more. Opinion or, now I'm going to get controversial, opinion-based or randomized controlled trial-based clinical judgment. Randomized controlled trials apply to small populations, which they have trouble with generalizability. I'm much more interested in population-based clinical judgment, getting data from large populations. Prescribing influenced by marketing. Evidence-based and value-based. Value-making, you're discussing with the doctors and the patients prescribing. Protocol care map-driven, tell the doctor what to do. Information-driven, give the doctor information and let she and the patient get together to figure out what to do. Lab test based on opinion. Laboratory testing based on predictive value. Discoordination of care, or integrated communication between professionals. Unable to foresee clinical or manpower needs. Better predictions and better resource allocation. Now, there's no guarantee we'll get into it. The real issue is up to us to design the systems that get us from the clouds to the sunshine. Some of that is just simply my own opinion. But it's going to be very difficult to get there. What will we gain, what will we lose? That's what I think. But I don't know if the gains are going to be so easily realized. That's the conclusion. So, those are Don's questions.